time to join, and we will talk to you in a couple of minutes. Thank you. And I'm CEO at Cognate Health. Just a little housekeeping for today. We are recording the session for those of you who may want to watch later or share with your colleagues. We are going to use the chat box function for anybody who may have some inquiries or questions. And if you would like to, of course, you can raise your hand at the end of the presentation as well. So thank you so much to everybody who has joined us this afternoon. We know we have people joining us from as far away as the US, so you're very, very welcome. And we look forward to interacting with you now in the next 30 to 35 minutes. So to introduce to you our speakers this afternoon, many of you will be very familiar with our own Professor John Gallagher, our Chief Medical Officer and founder of Cognate Health. We're delighted to have you here with us this afternoon, John. We were also to have Dr. Jane Grimes with us, the psychologist and occupational mental health lead with Spectrum Mental Health. Unfortunately, Jane has taken ill this morning, and we send our best regards, and we look forward to her coming back very soon in a speedy recovery. We are joined by Jane's colleague, Jane McGuire, who, thank you, Jane, for stepping in at the last minute, who's here to support with any queries as well that you may have. We'll look forward to outlining our Spectrum Mental Health partnership this afternoon. So where did this partnership come from? As you can imagine, COVID has impacted on so many aspects of our business. As it stands currently, 70%, that's 7 out of 10 of our initial referrals into Cognate Health are mental health or stress related. So to provide for our clients, and particularly you, our employers and your employees, we have put together a partnership with Connected Health and Spectrum Mental Health to ensure that we can offer you a service delivery that is second to none. Spectrum, as you may know, is Ireland's leading network of private mental health support primary care services and offers a nationwide clinical location with 17 locations of chartered psychologists and physiotherapists to complement Cognate Health's network as well. So I'm going to hand over to Professor John Gallagher, who's just going to set the scene as to mental health in Ireland currently, and also specifically speak to our partnership and service delivery as well. So thank you, John, over to you.
Thanks, Paula, and hi to everyone on this lovely fine day. Many of you still working from home, I guess, but hopefully not for much longer for those who want to get back to work, to the workplace, and hopefully continuing then for those of you who want to continue to work at home. Okay, Shara, if you want to go on to the next slides. The partnership, Paula's referred to that. So there's my one. I suppose, look, I've been in occupational health for 30 years now, and this is typically slide number 1 in the slide deck in the Introduction to Occupational Health series. The work and health, the two intersecting circles. And it's a good way of describing, I guess, what we do. In fact, when I think back to when I started a long time ago, I was talking to Dan Murphy of the Health and Safety Authority at the time, and they said to me, how do you describe what you do? I mean, what's occupational health all about? This is why I like this schematic. It really is the intersection between work and health. So you all know that your work can make you unwell. By and large, work is good for you. It's good to be at work, but work can impact on your health. And I guess what we do see quite a bit of these days is the impact of stress and stressful conditions in terms of people's health. And of course, over the past year, quite a bit of an impact as well from COVID-19 in terms of that extra stress and anxiety, etc. So work can affect your health, and we do see people refer to us where there's a query about the impact that work is having on somebody's health. But of course, the reverse also occurs where your health status can impact on your ability to work. And this is typically for those people that we're talking about today, with those with mental health conditions, anxiety, depression, and other mental health conditions, and how that can affect on somebody's ability, A, to attend work, and B, to be productive at work. So it's a two-way relationship between work and health. As Paul has said, we've certainly over the past year, we've been seeing about 70% of referrals would have a very large psychological component. Typically, I guess, in pre-COVID times, it was certainly up around 60% of cases. And that's probably where we will settle back into. I mean, and that is such a change from 30 years ago, I got to say, when it was way down in percentage terms in terms of the amount of mental health that was coming to occupational health. So we're certainly seeing much more presentation of mental health issues to occupational health services. And my feeling about it is that it's something that that a lot of employers struggle with, and I think in the overall, you'd have to say that most of us, for various reasons, tend to treat mental health problems a bit differently. It's probably not the right thing to do, but it is the way that it is. And as a result of that, we often see employers being nervous about reaching out and assisting people with mental health problems, and often then delayed referral. And we know that the longer that you have a health issue, and particularly a mental health issue, the poorer the outcome. So the longer it's going to go on, the longer somebody's out, and it all just tends to be very passive. And we were considering this, especially with the amount of mental health over the past year that we said, but why is this? So why do we deal with mental health problems differently to the other health problems that we see? So, the other big group was obviously musculoskeletal. Somebody gets sent to us with a bad back. It's much more active. We're saying, okay, we have physiotherapy, MRI scans. It's much more active in terms of engagement and in the rehabilitative return to work process. And it's different in mental health. It's one of those things. We're not going to go today as to why it is different, but it is different. And we thought, well, why are we so passive? I mean, typical examples would be somebody, these days, for example, somebody's put on a performance improvement plan, and next thing they go out sick with stress-related illness, and immediately there's a sort of a pullback from trying to actively manage them. Somebody with more mild psychological symptoms, again, just standing back. Even with more severe symptoms, they tend to be, leave the person alone in case you make them unwell. We thought there must surely be a more active way of managing or assisting with mental health problems. And that's where this came from. It was in considering this, and we do like to think that we innovate a lot in cognate health. We thought, okay, what can we do about this? What can we do about this to assist not just the employer in the situation, but also the employee? What can we do? What can we bring? What sort of service can we bring to improve it for everybody? This should be a win-win. So I mean, that's really where this service came from, and let's just run through it and talk a bit more about it. Okay, Charlotte. So mental illness, the continuum of mental ill health, it goes all the way from, you're absolutely well on one side to being very, very unwell on the other side. And of course, none of us want to have flat moods all the time. Life brings different challenges. Our moods go up and down from day to day, and that's the way it's supposed to be. That's living a normal life. But you can get minor symptoms, mild to moderate distress, and then obviously more significant mental illness. And thankfully, more significant mental illness is less common in terms of its presentation. So I'm thinking there about people with very severe depressive illness, suicidality, psychotic illness, schizophrenia, bipolar disorder, etc. on the very right side of that spectrum. On the left-hand side, you've got all of us, hopefully, who've got normal health and well-being, and in the middle, those with minor symptoms, with mild to moderate distress. And we do know that about 1 in 4 people in any given year have got mental health problems. So it's very, very common. It does obviously impact on people's functions in different ways, and of course it impacts in terms of the workplace. So that's the way that I look at mental health on a spectrum, and at any period in our life, any of us can be on that spectrum, any place. And what we're doing today is trying to work out what can we do now to assist the person and the employer in terms of mental health. Okay, Charlotte. So mental health then concerns us all. This is the scale of the problem, and these are some useful figures. About 1 in 5 people of working age experience a mental health problem. Mental health problems account for up to 30% of consultations with GPs in Europe. Look at that figure. Almost 1 out of every 2 families will have a member who has depression at one point in their lives. Most of the minor problems get better themselves without any formal treatment. And what we're certainly not trying to do here is medicalize a problem. Okay, we fully recognize, and that's why we work together with Spectrum on this, because we don't want to medicalize problems. Medicalizing things like stress may not necessarily lead to the best outcome. Okay, what we're trying to do actually is take the medicine out of it by and large and move the person along, get activity back into it, get the person into a pathway to recovery, part of which is getting back to work. The more severe mental health problems then are quite rare, only 1 to 2% of the population. And obviously some of those may need specialist assessment and care. So what we do know is that the majority of people with mental health problems are quite capable of continuing to work productively, and in fact it's good for them to be at work, and it is, it should be part of what we do to try to enable people with mental health problems to get back to normal work and normal functioning, and work is part of your normal everyday life. So early return to work should be part of that recovery and rehabilitation. Okay, Charlotte. So these are just 3 good reasons why we should do something about this. We've said some of this already, but I tend to like 3s. I always do. It's things tend to fall neatly into packages of 3, and it's easy to remember. One of which is cost, and I have a slide on that in a second. And we do know that mental health is costly for employers. Of course, there are legal obligations, which we'll talk about in a second. And look, it's good practice. You'll all know that we are moving more and more towards wellness as an outcome for employers, and or the way that we see things moving is a closer and closer integration of safety, health, and wellness into the connected health approach, or the total work health approach. And wellness is going to become just something that is going to be much more of an issue for us as we move forward, in terms of bringing those 3 pieces together. A lot of the times they function, as you know, very separately. Got safety over here, health here, EHS here, and wellness someplace else again, and that's not always the best way. So we'd certainly see this going forward into more connection, and the good employers see wellness as being a very important piece for them in terms of being the employer of choice, reducing churn, and more productive employees, etc. So let's move on and just have a look at the other arguments, one of which is cost, Charlotte, the organizational cost. So we know that mental health problems are among the most prevalent causes of sickness, absence, and work disability. So depression, anxiety, and stress are the leading causes of long-term absence. For every employee suffering from stress, depression, or anxiety, 17 working days are lost. So that's a lot. And then we know, again, I mentioned this earlier on, early identification leads to shorter sickness absence in people diagnosed with anxiety and indeed with mood disorders. Okay, Charlotte. So what about the second part, which is the legal imperative? Okay, and the 2 big bits here, obviously the safety, health, welfare, safety, health, and welfare at work legislation, and before I come back to that, as a sort of an aside, the employment equality legislation, and of course the obligations with regards to reasonable accommodations in the workplace. The first piece actually is quite interesting. So you'll know our original act back from 1989, and it closely mimicked the Health and Safety Act from the UK, which came forth from the Robins report. Interestingly, if you go back and read the Barrington report, which was the sort of which was the report from whence this legislation came, welfare actually is one of the key issues, and it was one of the differences between ourselves and the UK in the thrust of this. But welfare was very, very prominent. Now you'd have to say that for the first 10 years, very, very safety orientated in terms of its impact. Then more health beginning to kick in terms of stress and other health issues. And now we're certainly moving into welfare. So even in terms of the way our legislation is framed, there is a connection. And of course, you'll all know that your legal obligations do, with regards to mental health issues, largely rotate around the management standards for stress in the workplace. And those are outlined on the right-hand side. So your risk assessment is based around the management standards for stress. And that could be a whole extra webinar. The employment equality legislation then is the second part. And of course, this has a particular approach to disability. Many mental health problems will be categorized as disability, and therefore you've got the consideration of reasonable accommodations in the workplace. And I think certainly this is something, again, that this health service, mental health service, will be useful for in trying to outline, okay, what might work, what mightn't work, in terms of the accommodations that might apply in the workplace. Okay, sure. Okay, so look, this is our intervention timeline in terms of how Cognate Health goes about assisting both the employer and the employee in terms of absence from work. Okay, and you can see on the left-hand side, you've got pre-absence and then out of work, early intervention, interval assessment, and complex cases. And we're sort of building in interventions along here to assist you. Certainly in terms of pre-absence, the whole area of health promotion, wellness, resilience training, etc., is key, and will reduce the chances of somebody going out of work with a mental health or other problem. We've got in Cognate a day one early case management service, largely an occupational health nurse advisor based service. Again, the earlier that you intervene, the more likely someone is going to rehabilitate back to work more quickly, which is better for them and of course better for the business. So we promote early intervention and particularly for mental health problems. Early intervention then is the next one, and we'll talk about the mental health service in just a moment. And then you'll all be familiar with your typical interval assessment, which is actually where we tend to see a lot of people coming through at the moment for mental health and other problems. That's typically by the occupational health physician. And we're also building in now a more complex case assessment mechanism for mental health cases and indeed for other cases, for those cases which are particularly complex. So really it's recognizing that just having an occupational health physician assessment is fine, it'll meet a need, but there's an awful lot more that can be done in terms of assisting employers and employees with regards to health and work. Okay, sure. At last, the Occupational Mental Health Service. So some of you are probably thinking, will he ever get onto the Occupational Mental Health Service? So here it is. And you can see we've built it out in three different strands, okay? The first strand at the top, 1 second, I've just got to see if I can just get part of that is blocked from me. That's good. So the best way of looking at this, and we started off thinking, we need to build in a psychological assessment. What's there at the moment for you, okay? When somebody presents with a mental health problem, by and large, you can offer them the employee assistance service. Okay, now EAPs are very, very good, and I still see a need for EAP services. The difficulty is that it's still very passive. You're giving somebody the number of the EAP service, you're saying, maybe go check the EAP service and let's see how we get on. And we feel that we can bring more activity into that And the other difficulty with the AP service is you rarely get reports back in terms of trying to actively manage and case manage somebody's absence from work. So we thought, okay, well, what can we bring to bear here? And initially we thought, well, okay, well, let's build in an assessment. And we said, well, do all assessments need to be the same way? And we started off actually with a complex clinical assessment, which is actually a two-phase process. Again, I have another slide in a second about that. And we said, this is really geared towards people who are out longer term, more significant mental health problems, not going anywhere, typically might be on medication, might have tried EAP, and are just really drifting from interval assessment to interval assessment to interval assessment with the occupational health doctor. And it's all just very passive, and months and years can go by. So we said, okay, let's build in a complex clinical assessment with regards to that. So that's where that one came from. Okay, that's probably the high-end assessment. He said, okay, but does everyone need a complex? Not everyone needs a complex clinical assessment. Would it be of benefit to have an early stage assessment for people? Okay, that case management could refer into. So yeah, that actually makes a lot of sense in terms of what we see and in terms of utility to you. So we said, okay, we can have a brief consultation. So this would be for people with less significant mental health problems, possibly reactive problems to issues in the workplace, stress, burnout, exhaustion, people just struggling more than they should. And we're looking for sort of guidance in that situation. Look, is there something significant here from a mental health point of view? Does this person need to be signposted in a particular direction? Maybe EAP is appropriate, but we're doing a referral and we're getting a report back in. Okay, and that's a key part of this. So we've got the two assessments, the early stage one and the later stage one for the complex cases. We said, okay, that's good, but I mean, their assessments, what about some psychological treatment? Because let's face it, the public health service is under a lot of strain. And if you get referred for public health and mental health services, you're probably going to be waiting months unless it's very, very acute, in which case you're going to go to one of the mental health units. So, and that's not going to change. I mean, that's the reality. That is the way it is. And look, I mean, even if you want to get an addiction assessment done for somebody, there is a wait time. So we said, okay, can we bring something here which is outside of the public health service? And we have brought a referral into psychological treatment, again with Spectrum Mental Health, to bear inside here. So I think this will be very, very helpful again because of the strains in the public health system. I think this will be very useful to have, particularly for those people. I think these will be time limited, by the way. This isn't something they're going to go on and on and on and on and on with. It's very much focused and aiding the person in their rehabilitation and return to health and return to work. So that's actually where we got to. Two assessments, one early, brief consultation, used more frequently, obviously, one later, complex clinical assessment, used less frequently for more significant mental health issues. And then the actual treatment piece, okay, the actual referring somebody in for assistance with their mental health issue. Okay, Shar. Okay, so, and I think I've probably said these. So the brief consultation, it really consists of a mental health and psychosocial review. And again, because we're working with Spectrum Mental Health as our partners, there will be a focus with regards to the work in particular in this assessment, and indeed with the complex assessment. Reporting, the report will flag any areas of concern, and will give guidance then for occupational health and of course onwards to yourselves with regards to next steps. The more, where'd you go to? Go back one, well done. So post-assessment referral then will be tracking progress against the initial assessment and progress support to occupational health. So it might just be a once-off referral, possibly another referral to see how they're getting on. But either way, there will be a referral in and a report back and tracking of progress. Okay. Thanks, Shar. Next one. So this is the psychological treatment and care pathway. So there'll be a discussion between the manager and Cognate. Manager, of course, will be in discussions with the employee. Cognate refer onto the Spectrum Mental Health team, clinical intervention with psychologist treatment, and these are all accredited psychologists based on needs, and then discharge once the treatment goals are reached. So you see very much this is goal orientated and within defined timelines and outcomes. Okay, sure. And one thing I'd say to you is that with regards to entry into that treatment piece, not everyone may need to go through the assessment process. It may be something that you're going to make available to particular staff who want to get particular psychological treatments done. It's likely, I think, that many will come from the assessment process. So, you know, what would you see in terms of the first one? Your typical brief consultation might be somebody who's just struggling, and you're having your conversation. It might be performance review consultation. It might be a return to work assessment with somebody. They're saying, look, I'm struggling with the work. I've got issues going on. I need to get some assistance. And now I think you now have an option of getting an assessment. In particular, I think that early stage assessment will be very helpful there, and then possibly entry into a particular treatment program. The second one, then, the more complex clinical assessment, will be somebody typically who's out for a much longer period of time, more significant mental health problems, and needs a different type of intervention. The one thing about this, the second assessment, by the way, just so that I can, I thought we had a timeline out of Shari. You don't have a time up there for the second one, do you? Is that it's a two-stage assessment, okay? So and it takes us about 8 days between the two. By the way, earlier, Jane, you might want to say something about this in a second. Referral into this is very quick. It's about 7 to 10 day timeline to refer in for these assessments. And then the more complex assessment is a two-stage process where they will have an initial assessment with the psychologist, and then return for a review of that about 8 days later, and then the report is produced. So it's obviously much more complex assessment, but it's all built around trying to get activity and momentum back into the case management process. So what are the benefits to the employee and employer? And I'm hoping that as I'm talking here, you're thinking to yourself, actually, this makes sense. There is a benefit here to the employee, and look, we're reducing their stress, we're promoting health and well-being. They become more productive. Earlier intervention, so the longer somebody's left to continue, the harder it's to solve. So we know that early intervention is better, and then benefits of an early return to work as part of their overall rehabilitation. And never underestimate the positive mental impact of work. Okay, people who are off work tend to have more depression, more anxiety, more morbidity. For the employer, you've got active management of issues rather than passive, better morale, better motivation, less presenteeism. This is really when people are at work when they shouldn't be. Reduced labor and legal costs, reduced short and long-term sickness absence, improved retention, reduced churn. And if I just put that slide up and you're ready to say, yeah, okay. But I hope in the rest of it, I wanted to explain to you the genesis of this. We said that this is really, we want to bring something here that just does not exist. I'm hoping that's resonating with you, that for many people with mental health problems, they just wait, wait for recovery and wait and wait and wait. Okay, I think the next one is probably our last one, Charlotte. Yeah. Oh, I did have a slide inside there before about training the manager and how to support the employee. So part of this, of course, is that if you're interested in this, we would facilitate more training and possibly workshop in terms of the approach to occupational mental health and the whole referral pathways that are there. So Kira is your main referral point here from a cognitive health point of view, and she can be reached. Probably the best is at that address. Kira is our newly appointed sales and marketing manager. So look, thank you very much. In summary, I think it is something very new, and it is in response to what we think is quite a deficit. We think it's good for the person with mental health problems, which could be any of us. It's good for the people who don't have mental health problems now, but who may and probably will develop them at some stage. We think it's good for employers to have extra choice in where they refer people to. And we think it's very good in that we feel it's more active than the current largely passive approach. So thank you all very much indeed for your attention.
Thank you, John, much appreciated. And I think it gives a clear outline of our partnership. And as mentioned earlier, we are delighted to be able to partner with Spectrum Mental Health. And as you say, John, we're bringing something to the market that doesn't currently exist at the moment to support our clients. Just to advise, as John mentioned, the appointment system is very, very swift. You will, and anybody who refers into the assessment program will have an appointment within 5 working days. We've made that commitment to you, and a report then within an additional 3 to 8 days of the clinical assessment as well. So it is a very swift response time in comparison, as John said, to other avenues and parallel avenues as well within the public health system as well. We will open it up to the floor for some questions. If anybody does have specific questions around the mental health assessment consultations and program. I do have a couple actually, John, who've come through already, so I may just throw those at you if you don't mind, if that's okay.
Sure.
I suppose, John, as mentioned as part of the presentation, certainly we've seen a heightened level of stress and anxiety during COVID. With the return to work protocols coming into play now, are we anticipating that will reduce? Or do employers really do have to consider that this is going to be something that will have an impact for a further 6 to 12 months on their organization?
Wow, goodness me, we could do a whole post-COVID presentation here. Return to work is something that we're all grappling with at the moment, including ourselves, Paul, as you know, in terms of how is it all going to work for people. Certainly there is a mental health association with people working from home in terms of loneliness. Okay, and this is something I think that's going to be important for all employers going forward. Is just recognizing that if you are maintaining a remote workforce, you need to make sure that you're including them as part of your regular workforce who are on site, and don't differentiate between them, and in particular reaching out to them, making contact with them, including them in everything that's going on, and just being aware of the issue of loneliness. And look, again, I think this product could be useful, the service could be useful from that perspective. A lot of what we do now is remote, as you know. At one stage, I mean, about 18 months ago, I'd have said to you that 2% or less of consultations were remote. We moved to virtually fully remote last year. We're back down to maybe 60 or 70% now. And I think we'll probably end up at around sort of 50% or so remote, mainly because that's the way it's been in the UK for quite a long time. But it just works for people, you know, especially for mental health problems. What you do realize is that for a lot of staff, even coming in for an assessment on site can promote a lot of stress. So we find actually that the remote consultation by video or indeed by telephone, but video preferably, is actually a very, very useful consultation mechanism in reaching out to staff who've got mental health problems. And of course, that applies very much for people who are remote working. So I think I'd be conscious of people who are going to remain remote. I think I said this in my last webinar. The people that you want to have remaining remote are the people who want to remain remote. You're going to get into difficulty all the time. It's a bit like shift work. If somebody's struggling against something, it's just going to lead to pressure and stress. So working with people and trying to establish what is their wishes is just going to be such a key issue here in saying, you know, what, of course, within the realms of your service needs, but working with people and trying to find out, okay, what would you like to do? Because we do know that a substantial proportion of people would like to continue with some element of remote work. So I think a key piece going forward is working, establishing who wants to work, what's sort of blended. Most people I think would like blended rather than all one or all the other. So look, there's lots of options, and with options, honestly, if they're used properly, with engagement and with consultation with the staff member comes opportunity. I think where you don't want to, where you misuse those options, if you say, well, look, a bunch of you are going to remain working remotely, it's going to be everybody from A to F on the alphabet this week, and F to whatever next, etc. So when you're imposing things, there's a risk of problems. So look, I think remote working is good. Watch out for loneliness. The remote consultations are very, very useful in reaching out to those staff groups. The other part of this, of course, is that yes, you will see people who still have got anxiety now about coming back to the workplace. I think vaccinations will have done a lot in terms of quelling that for people, but so we are still seeing, we're doing a lot of return to work consultations now, particularly people who've been cocooning for the last year and who are wanting to get back to the workplace post-vaccination. But for those, and indeed for others, there will be a nervousness. There has to be. They're out for nearly 18 months. There's going to be a nervousness about getting back to the workplace. Engaging with them, discussing the return to work protocol, letting them see the organization and arrangements that are in place for them before they get back in the workplace, all will work in terms of reducing that anticipatory anxiety. And then for people, again, who've got very, very significant fears about going back to the workplace, and look, my experience is that often that's people who maybe have unwell people at home and they're still afraid going to the workplace and bringing something back, usually by explanation that, look, if you're vaccinated, really that risk is minimal to negligible. A lot of explanation will go a long way. So yeah, we are in an interesting place, much better place, I gotta say, than we were some time ago. We always knew that the vaccine would not make it all go away. I remember saying this quite some time ago, that this is not going to be a silver bullet. We do know that that those people who are vaccinated are just not going to end up in hospital by and large, unless they're extremely unlucky. And that is the outcome. Forget about the 300-400 number and just watch the number that are in hospital or being hospitalized, because that number is actually still decreasing. And that is the big win for all of us, I think. So sorry, I digressed there. Like I could have gone on about COVID, but there you are.
Wait, no, not at all, John. As always, we have a couple of other questions. Will there be any additional focus on those individuals currently under psychiatric care, i.e. those who may be in more acute cases?
I think we look. It's very important because so much mental health therapy is based around your relationship and trust with your therapist. So if somebody has been looked after appropriately, is making progress, you don't want to mess around with that relationship. Okay, it's not to say that you won't get an assessment done to see is there anything else can be brought to the mix. Absolutely, you can. But if people are progressing well with their therapist, then you don't want to mess around with that. And indeed, for those with the more significant mental health problems, our aim is yes, see are they getting the appropriate treatment, but also because look, in reality, there's very little discussion about return to work when people interact with the public mental health service, because they're short time frames. It's about how you're getting on. It's about your illness, etc. I think what we're bringing here is something that has got more focus on work and return to work and the rehabilitation process as an extra piece. Okay. If we can also make suggestions around their care pathways and treatment pathways, well and good too, but certainly our emphasis is on getting movement into it and bringing some momentum back into the process.
Great, thanks, John. Actually, we have a couple of questions now, so you're going to be put on the spot. Mm-hmm. We have an employee who's on a second week of stress from work. Should we offer the brief consultation now in the hope that he may be back sooner? Would that be a good fit, do you think, John?
Yeah, I mean, it'll depend on what you know about the person. I mean, you're probably going to reach out. First of all, if you see somebody putting down workplace stress, you do need to act. Don't ignore it and hope it's going to go away, because you're going to have to intervene at the very least with regards to the workplace and how it. What are you trying to find out? You're trying to find out what's going wrong. You know, what can we do to remedy this for the person? And this is where I say all the time, you know, stress and workplace stress really isn't a medical issue, and we got to get the medicine out of it and get the focus back on trying to resolve the issue in the workplace. So Why has this person got workplace stress? It's because something's gone wrong in the workplace. If you go back and look at the management standards, demands, control, support, etc., it's probably in one or more of those columns. So the assessment process there, if it's workplace stress, you might decide to go for an early occupational health physician assessment, or indeed an early case management assessment. It'll just depend on your knowledge of the person, how significant the problem is, from your point of view, what you know about the person and their previous functioning. Certainly for workplace stress, I'd say yes, do something. If you've got workplace stress on a cert, then I would say you should probably get an occupational health physician assessment early. Okay, that's my feeling about it. The actual outcome from that could be into the Spectrum Mental Health treatment service. It might be continue on with their own therapist if they're already seen somebody. It could be referred to EAP. But I'd probably pitch if you're seeing work-related stress on a cert, that's where I'd put it. Okay, I'd put it in for an early occupational health physician assessment, which is part, by the way, of the overall occupational mental health service.
Great, thank you, John.
Just to add to that,
yeah,
the way we've designed the service is very much that if someone comes in and they meet with the case manager or one of the psychologists, and we kind of think we've done the brief consultation, we feel that they could benefit from the full assessment. We can carry out that process just because of how we've designed it and brought it all together. So
that's right.
Once
Jane,
we do receive that referral, we can make those decisions.
So what we will do, and Jane, you're absolutely right. I think this is a joined up service. So we'll have our communication lines open. And if somebody, for example, gets referred into the first line service, but actually needs something more complex, then we'll go back to you and say that it actually needs one of the other ones. So it doesn't have to be either or is what I'd say to you. And certainly we'll be communicating internally with regards to the most appropriate referral.
That's great. Yes, and thank you, Jane, for that as well.
And Paula, by the way, for anybody who has that sort of query, I'd say pick up a phone and ask. I say, look, what do you think is the most appropriate referral here? That's the easiest thing to do. Yeah.
That's exactly it. Absolutely. Another query, John. Can you please tell us a little bit about the consent and clinical governance associated with this partnership?
So the clinical governance for the psychology service will rest within Spectrum Mental Health. And Jane, if you want to speak to that in a second. Obviously, in terms of when people are referred into Cognate Health, we have got a clinical governance process inside there. Everything that we do is consented. Okay, so if somebody presents to us, they've got A, consent to the consultation taking place, and B, consent to a report. And if somebody doesn't give consent to a report being provided, and they're there for an assessment, there's probably no point in the assessment taking place. And we do that right at the very, very start. So everything that we do is guided by consent. If somebody doesn't give consent, then we were unable to give a report in that situation. By and large, it happens so infrequently that it's not a major issue. But yes, everything we do is guided by the normal standards when it applies to medical ethics and indeed confidentiality. Jane, did you want to say anything from Spectrum?
Yeah, sure. So just to speak to the consent part, we'd also carry out we'd get consent from the individual psychologist would get consent from anyone that's been referred in, and would talk the employees through that. And then on the clinical governance, we would have our own internal clinical governance team, which is a psychologist-led team, including our clinical director, who's a clinical psychologist, Jane, who's not here today, our mental health lead, and then another couple of psychologists as well who would review cases, making sure everything is within clinical best practice.
Yeah.
Thanks for that, Jane. And I know we had lots of discussions on this to make sure it was fit for purpose when we were bringing the partnership together as well. So I think we can assure people we've done the due diligence on this from both aspects. Yeah.
So look, just going back to that, in terms of the referral pathway with the assessments, don't worry, pick up a phone and talk to us. And if somebody gets to see one of the occupational health doctors, and the doctor says, this could actually really benefit from the occupational mental health service, they're going to come back to you and say, look, we think this person might benefit from referral to the occupational mental health service, to see whether you want to approve of that or not. So we'd like to think, the reason we got together with Spectrum Mental Health is because we think they're the best in the business, good clinical governance, operate to the same standards as ourselves, and we're very much into having a joined up solution to making it easy for you, so that you're not just trying to work out, does this go to A, B, C, D, or E? Yeah, sorry, Paula.
Oh, not at all. Just another one there, John. Somebody's just raised an interesting question around, and you alluded to earlier, training managers. I mean, it's a difficult conversation to start with an employee. So what are the first steps that a line manager or a supervisor should take?
It's probably best if we don't get into a full training session now, but I'd have a couple of thoughts about that. Do you want to say anything, Jane, or will I just go into that?
Well, just to touch on, we do have full workshops and all the rest that we could implement across any organization that was interested in it. And if the Occ Health was something they'd set up, we can talk them through how exactly they'd refer in, when it's appropriate, when it's not, that kind of thing.
I guess the one thing about mental health look at the big issue is occupational mental health has still got stigma attached to it. I mean, that is a fundamental issue, and that's probably why we treat it differently. I spoke with this earlier on, and sort of coming back full circle now. That's probably why we treat it differently, and it is more challenging for managers, because they have a number of fears when they do this. They have a fear that the person is going to react badly. They've certainly got a fear that they're going to make matters worse. They have a fear that, am I doing the right thing and asking any questions at all? They have a fear about, what questions should I actually ask here? It's different to back pain, but you say, look, how are you doing? You're getting out and about. How do you do that with mental health? And I think it's, being human is probably the best thing I'd say to you. You're just generally inquiring how the person is doing. You don't need the specifics about who they're seeing, what medication they're on, and all of that medical side of it. But you want to be human and see, are they looking after themselves? Is there anything else that you can do, offering assistance if they feel that they need help? And most people actually respond to that a quiet room, the two of you talking together, for most of the mental health issues that'll present. People who are struggling, are you okay? What a simple question. Are you okay? Do you need an assistance? Is there anything that we can help you with? And just opening up that conversation with the person. And in many cases, that'll open some doors. And of course, going back again, and all of you in HR will all recognize this as being good HR practice. Going back again and inquiring, are they doing okay? That's for and doing that early. Not ignoring if somebody is struggling. Then there are other warning signs with things like addiction. Missing a Monday mornings, coming to work, falling asleep, all of those things which present all the time. So that'll have a particular approach. And I mentioned earlier on that one of the things we can do here is get addiction assessments done on your behalf. All the way through to then somebody who is out sick for the longer term. And I think, again, the thing to do is not to ignore it, but to reach out in the same way, trying to assist. And we do like to think that people will be interested in an early psychological assessment to see, is there anything else can be done? That's why we built that inside there. And then, of course, the treatment program, which is the extra piece to this. So we see a number of different needs inside there. Paula, coming back to your question, I think it's actually, instead of doing what people feel most comfortable doing oftentimes, which is stepping back a bit from it and saying, well, let's leave them alone in case they make matter worse, is step forward and be human and make the inquiry. Are you okay? Is there something we can do? Is there anything about the work that we can assist you with? Is there anything else we can help you with? Just those general inquiries early would oftentimes open doors.
Excellent. Thanks for that, John. And as you say, Jane, we actually have a full program associated with Spectrum Mental Health as well to support managers and line managers as well, and that training can be offered too. We have 2 or 3 more, John. we're motoring through at the moment. One query is, I'm working an occupational health role in a global headquarters here in Cork. We recently launched a mental health program for on site and have put a team together. You mentioned, John, the lying in wait for people. Any ideas on how to promote to people with issues coming forward and developing our culture around mental health?
So what was the...
So how would we basically, the team is now, mental health program has been set up now on site for an organization.
Okay.
And you had mentioned a little earlier that, you know, the people that are lying in wait that are, you know, not going to come forward. How do you actually promote for those people to come forward to you and promote that culture of good mental health?
So look, this is right up Spectrum's alley, I think, Jane, isn't it? In terms of the offerings pre-absence, isn't it? In terms of the what can lead to a healthy workplace from a mental as well as a physical point of view. I know that you do a lot of work in this area, Jane. Do you want to speak to that?
Yeah, sure. Yeah, so we'd have a full range of programs to kind of to generate that positive culture and make us a company feel for employees like a space that they can come forward, and we can do full kind of consultations with key stakeholders around instilling that culture, from seminars, employee workshop, manager workshops, as well as our first responders training, where we train groups to it's kind of mental health first aid, so that people can kind of respond to crises. And even just having those people across the teams creates those spaces within those teams for people to come forward and have a chat about whenever they're struggling. We have a mental health ambassadors program where we can help select and support key members of the team in telling their own mental health histories and stories and how they came through something, and kind of roll that out as videos and blogs, so that again there's kind of a recognition that it is a place where mental health isn't stigmatized, and they can talk about it just as much as they would back pain or anything. But I can send on kind of brochures and any products on too. I think it was Sir who asked the question.
And I think, Jane, I think I'm sure you will agree that when you get it out there, when it becomes part of the discussion and you start normalizing that mental health conversation, then people feel enabled to bring problems more openly. I'm sure that's your experience as well.
Yeah, no, exactly that.
We probably certainly have seen that as a nation, certainly through COVID as well, in that support. I think we're ready to kind of wrap up time-wise. We did promise we would have everybody off on a timely fashion. I would say that Jane, one of the I suppose the key percentages that was shared with us, with John and I, when we started this journey with you, was that research has already shown that 86% of employees who are treated for depression report improved work performance. So to John, as your point already, it does work, and the early intervention does work as well. And again, as part of that study, treatment of depression has been shown to reduce absenteeism and presenteeism by 40 to 60%. So again, it does work. And I suppose that's what we're trying to do today is give everybody the steps to make sure that does happen and that early intervention happens as well. Jane, anything you want to say from a final perspective from Spectrum Mental Health?
No, I think we kind of covered off everything. We can share briefing documents and brochures for anyone who needs more information. But like as John shared, just to get in touch with Ciara on that email address shared for anyone interested in setting it up.
That's excellent, Jane. Thank you so much. And John, as always, thank you so much. Just to let everybody know, as we mentioned, we are recording the session, so that will be available to you later. And we will be providing an informational pack to you, exactly outlining, as we've discussed today, and how the referral process can be used as well within your own organizations. So really just stands to me to say thank you so much. Thank you to the nice comment that's come in about our excellent new service provision, and thanks for the lovely presentation. Great forward thinking on behalf of Cognitive Health and Spectrum Mental Health. So I think that's a really good point to finish on. And again, to everybody, thank you so much for your support today. Thanks to everybody.
Thank you.
Have a good day. Bye.
Thank you.